While making an ECG, the doctors or nurse or any health professional, any health practitioner doing an ECG must consider these 4 points to make the best outcome of the ECG. So the first is, while attaching the electrodes, we must be sure that we are attaching the electrodes in the correct limbs. The right for the right and the left for the left, and the correct position of the chest leads should be kept in the right anatomical position from the B1 to B6, and we have the anatomical position, and we must be keeping those electrodes in the exact position where they are considered to be. And the next is, we must ensure the good electrical contact of the electrodes that we are attaching. We must be sure that there is no any oily surface, the skin is dry, and there is no any hair or any obstructing things between the electrodes and the skin. And the next is, we must check the calibration of the ECG and the speed setting, whether it is 25 millimeter per second or the 12.5 millimeter per second or 50 millimeter per second, or it is in the 1 millivolt equals to the 10 square box or the 10 centimeter, or the 2 square or the 20 small square box equals to 1 millivolt or the 5 millivolt. So we must check the calibration and the speed setting, and we must get the patient comfortable and relaxed so that they do not move and their electrical waves of the skeletal muscle doesn't come in the ECG. So we must be able to keep them in the comfortable and the relaxed position to make the best outcome of the ECG. So let's start about those things one by one. So starting with the limblets, we will keep the limblets in the right upper arm, left upper arm, right lower limb, and the left lower limb, and we'll be keeping that lids above just the wrist joint and above just the ankle joint. And before starting that, we need to know that there are two criteria of which the limblets are chosen, and there is European criteria and the American criteria. First, we'll start with the American criteria. In the American criteria, we'll choose the limblets of the color white, black, green, and red. And to understand this, there is some mnemonics that I'll be talking here about. White people think they are always right. So here is the white, and here is black. Here is white, and here is black, and here is green, and here is red. So white and black in the upper arm, because it is in the American standard. There is white and blue, and white it's the right and left. We will define it by B as white people think that they are right and black are wrong, so it lies in the left. And white associated right limb and associated left limb, and the white people, they consider themselves as the green flag, and the black people they consider them as the red flag. So associated left limb will have the red, associated right lower limb will have green, and the white in the right arm and the black in the left arm. So by this mnemonic we can understand that which color has been used. So you can see over here, there is white, here is black, right upper arm, left upper arm, and the corresponding right lower limb will have green, corresponding left lower limb will have red, because they consider themselves red flag. This has the green flag. So white, black, green, and red. So then after, in the European standard, you can understand this by the mnemonic right ear, green, black. So right ear, green, black, red, yellow, green, and black. Right ear, green, black. So right upper limb, left upper limb yellow, left lower limb green, and the right lower limb B, black. But mostly in the Nepal, you will see the following European standard: right ear, green, black. Okay, if there is white, then that will be the American standard, and if there is yellow, then that will be the European standard. You have to look which color has been being used, because the rest, the green, green, black, and red are usually present in both European and American. You have to see for whether there is yellow color or the white color. If there is presence of white color, then you must understand they are going to follow the American standard, and if there is yellow color, then they are going to follow the European, and that will be at the mnemonic right ear, green, bike, right. Red, yellow, green, and black. And in the American standard, white and black, white in the right, black in the left, and the corresponding white for green in the right leg, and corresponding red color in the left region. So right forearm or wrist, left forearm or wrist, and the left lower leg proximal to angle, right lower leg proximal to angle. We know that the ECG should look, and why does it look like, we have already known from the previous videos. And there will be one ECG record will always produce not most of the time, but there are some strip that we consider as the rhythm strip, and usually the lead 2 are used as a rhythm strip, and this is particularly useful when the rhythm is not normal. When the rhythm will not be normal, then that can be lead 2 can be looked upon, and we can define the rhythm. So let's look at the limb 2. So this is used as the rhythm strip, because here we have 1, here 2, here 3, BR, BL, BF, B1, B2, B3, B5, and B6, right? And you can see in the lead 2, and in the lead 2, for the rate and rhythm, we will see how many RR intervals are being made, and we have seen here how many boxes are R. These are the R wave in the lead 2, right? Now, and for the rate and rhythm, we will see how many boxes are being made. 1, 2, 3, 4. 1, 2, 3, 4. 2, 3, 4. 1, 2, 3, 4. You can see here the rhythm is regular, and this is the lead 2. This is lead 2, and most of the time the lead 2 are used as the rhythm strip. Okay. and in most of the ECG the lead 2 will be also be recorded and be printed as the rhythm history, but most of the time they are printed but may not be found in all the ECG, but you have to, but still you can see the lead 2 to find the rhythm. So here is regular. And what is the heart rate? I have said that 300 divided by the RR. Okay, 300. And how many boxes are there? 1 2 3 4. How many large box? 1 2 3 4. 300 divided by large box in the RR interval, large box. So 300 divided by 4 equals to 75. So the heart rate is 75 beats per minute, and this is normal. This shows the P wave. So this is the regular. And it is really important to make sure that the electrode marked the left LA is indeed attached to the left arm, and right RA is attached to the right arm, and so on. But what if they are wrongly attached? For example, if the red, for example, if you see the red had been kept in the left arm in the European and the yellow has been kept in the right arm, so what will be the ECG? Or in case of American, W has been kept in the right and black has been kept in the right arm. So what will be the reading of the ECG? Because they are being exactly opposite. So we can see here. It is really not important because you will not make such mistakes, but still if you make such an error and you see the ECG finding, then you can see over here there will be the change in the I and the VR. You can see in the I and VR. As you know, we have already mentioned that if this is 1, then this is a augmented VR, this is augmented V left, and this is augmented VF, and this is 2, and this is 3, and this is the depolarization. Depolarization wave will be here, so it will be reading opposite. So in the AVR you will see this is the P, and then this will make the Q, then the R, then S, then T. So you will see the opposite in case of AVR, like you will see here. In the AVR you can see that the P wave is inverted, and then after the Q RX complex is also inverted, then the T also inverted, P inverted, QRS inverted, T inverted, because they lie in the opposite. You can see P, QRS, T, they are inverted or deflected downward because they lie opposite to the wave of deceleration. But you will see over here that the PQRS is being erected upright, P, Q, RS, and T. And you will see the P upright, T upright, P upright, T upright, P upright, T upright, which is very unusual in case of the VR. And also you can see the in the lead one of the same, that the P is inverted, QRS, and T also inverted, P inverted, T inverted in the 1, which is very unusual. Okay, there would have been the angle of left axis deviation or the right axis deviation. There would have been the question in the change of the P, Q, R, S, but you can see the I and VR, but they are being exactly opposite. I and VR, you can see here P is upright, Q, and then T, P, Q, and T, they are in the right. But this will happen in case if you interchange between the right lead and the left lead of the upper arm. So this is the things that you can consider if there has been change. And I have mentioned also sort of why this is recording in the opposite direction, because you are keeping the 1, because the 1 lies over here and the AVR is here and the depolarization is here. And so this will read the opposite, because P reflection, Q will be down, T will be down in here, and here will be the P, because it lies along with the wave of depolarization, P, Q, R, S, and then T will also must have been the upright, because it is going towards the lead and it is going away from the lead, so opposite. But if you change the AVR over here and if you keep the lead 1 over here, this will show the opposite reading. That is why that will show the opposite reading. Okay. So now the question is, what happens when we will change the lead of the limbs? Like if the left is kept over here and the right is kept over here, then there will be not so much of change, because the right is used for earthing and it is used as AVF. So the AVF will be recorded by here, but there will be not so much of change in the direction while measuring here, and this will act as the earthing and it will be here, but it is usually used over here. There will be slight change in the deflection, but there will not be any gross changes during the change of the lower limb. Now the test electrodes need to be accurately positioned so that the abnormal patterns in the leads can be identified, and so that records taken on different occasions can be compared. Okay, and we need to know the position of the limbs. So B1, B2, B1, B2, B3, B4, B5, B6, and B4, B5, B6, B6. B1 lies in the left intercostal, fourth intercostal space. Right sternals, B2 lies in the fourth intercostal space, left sternals, and the fifth intercostal space, mid clavicular line is the placement of the B4. This is the mid clavicular line in the fifth intercostal space. This is the fourth intercostal space, and the junction between the B2 and B4 is kept as the B3, and the B5 and B6 lies in the imaginary straight line to the B4 or the fifth intercostal space, in the anterior axillary line and the mid axillary line. So you can keep this just little like this, but still in some other we have posterior B7, B8, and B9, so in the posterior aspect of the trunk. So these are the waves of the B1, B2, B3, B4, and B5. So you can see the normal reading over here. and you can see that P, there will be the not so much of deflection, small deflection, then there will be the R, then there will be the S, then there will be the T. But in the V6 you can see that there will be the P, there will be slightly small, and the large because of the ventricular mass, and then the T. As I have mentioned this earlier, why here occurs more and why it is negative and why it is positive. I have already mentioned the QRX complex is positive over here, there is negative, and in the B3 and B4 it will be equal because this will denote the septum, and I have already mentioned about it, so you can read about the B3, B4, B5, B6 from the previous lecture in the QRX complex. So these are the things that is to be known for the making of the practical points for the recording. Before we do any of the ECG, then first of all the skin must be clean and dry. The skin must be clean and dry, and if they are using any of the moisturizer, any cream or any oil, then first that should be cleaned with the alcohol, and then after it should be wiped off before applying the electrode. Because the abrasion of the skin is essential in most patients, all that needed is a rub with a paper towel. And if we are doing an exercise testing, then the patient is likely to become sweaty, and the abrasive pad must be used so that the test it is worth spending time to ensure good contact. Because in many cases, the ECG becomes almost unreadable towards the end of the test if they slipped off because of the sweat. And here is a poor conductor of the electrical signal, and it prevents the electrodes from sticking to the skin. So saving may be preferable for the patient, but it is not very convenient for the patient to remove off scale of their body hairs and just add that portion. So it might be uneasy, so they may not try to do so, but still we must insist them and try to make the good contact between the electrode and the skin. And if that is if the hair can be parted, then the firm contact can be made, and this is also acceptable. So but if we want to make the good ECG reading, then the hair must be saved if they have hairy body, otherwise the hair must be parted and the electrode can be kept, and this is somehow acceptable. And after shaving, the skin will need to be cleaned with the alcohol and soapy wipe. So this here we can see in this ECG, we can see what is happening here. There is the bizarre ECG patterns, and in the rhythm strip too, the patterns vary, and we can see here we must be PQRST, but we cannot see here PQRST. We cannot show some things like P, there is ventricular depression, but we cannot hear is P, ventricular depression, T. So it is being very hard. So we can study the step 2, and after studying the step 2 we can know that it has very poor electrode contact. So by reading this pattern we can understand that it is having poor electrode contact. Rhythm strip we can understand that it is not having good contact. We need to know that even with the best ECG records, electrical interference can cause regular oscillation in the ECG trace at first sight, giving the impression of the thickened baseline, because somehow there may be electrical device or if your mattress is being turned on or any electrical other interference is in there, then it will be giving the very thick baseline, and it can be extremely difficult to work out where the electrical interference may be coming from. But always think about the electrical lights, electrical motors on the beds and mattress, and remove it. Otherwise you can see over here this thickness, because of the electrical interference this appears thick. If you have any battery, mobile phone, electrical mattress, wiring, etc., and they interfere, then the baseline will appear thick. So this will denote the electrical interference. So this is for the electrical interference. And starting the other ECG recording, the ECG records normally calibrated so that 1 millimeter volt of signal causes a deflection of the 1 centimeter. Previously we have been saying that 1 centimeter will cause the 1 millivolt. That is 1 centimeter equals to 1 millivolt means this is the 10 centimeter, because 5 millimeter, 10 millimeter. This is the 1 centimeter, and this calibration is equal to 1 millivolt. This is the 1 millivolt. Okay, this is the calibration of this. Calibration signal usually appears at the beginning and often also at the end of a record. If the calibration setting is wrong, then the ECG complex will look so large or so small, which I will be discussing and showing you over here. Here it is when the calibration is made of the 2 centimeter, and this is when the calibration is just made up of the 0.5 centimeter. I will discuss what are the images over here. And the large complex may be confused with the left ventricular hypertrophy. As you can see, the left ventricular hypertrophy will suspect that this is either it is a left ventricular hypertrophy or not, and if that is very much small, then we'll be like confused with the pericardial effusion. Because we will see very small deflection, and we might be confused that whether it is pericardial effusion or not, because this may suggest that there is something like pericardial effusion reducing the electrical signal from the heart, and we must check the calibration. There are less visuals, so the calibration like 1. Before the starting of the ECG, there will be like 1, 2, 3, 4. There will be like this, which will be measuring the calibration 1, 2, 3, 4, and we must see the calibration. And if this calibration shows, and these are and B3, B2, you will see like they are being more, the QRX complex is large, P is large, T is large, T is large. So we might be confused whether it is a ventricular hypertrophy, but no, this is very normal ECG because the calibration has been made for the 2 centimeter, and the 2 centimeter equals to 1 millivolt has been made. So the images appear like this. And if the calibration is made for the just 1 millivolt, just the 0.5 centimeter, then they will appear very small, and we might be confused whether there has been any reducing the electrical signal from the heart, like there is the pericardial effusion or not. No, actually this is also the normal reading, but this has been occurred due to the because of the low calibration. So you must check it like this, like here, this is the calibration, this is the, here you can see the 2 box. So 10 centimeter equals to 1 millivolt, here the 5 centimeter is equals to 1 millivolt, here the 2 centimeter equals to 1 millivolt. So these are the things. So we must be checking the calibration before starting the reading as well. And the next the thing that we must be considering is the ECG recorders are normally set at the paper speed of the 25 millimeter per second. So the paper reading must be, but they can be altered to run at a slower speed, which make the complex appear spiky and bonds together, or to the 50 millimeter per second. The faster the speed is used regularly in some European countries, but and make the ECG look spread out. In theory, this can make the P wave easier to see, but in fact, flattening out of the P wave tends to hide it, and so this fast speed is seldom is useful. And you can see over here. So this is the calibration of the 1 centimeter. So 1 millivolt. You will always see the calibration. Okay, see the calibration whether this is 2 or 1 centimeter or 0.5 centimeter. Mostly you will see the 1 centimeter, and this will, if there is one, if there has been used as the 0.5, then this will be used seen, and if there is 2 centimeter equals 1 millivolt, then this type of ECG pattern will be seen. So you have to see the ECG pattern first you have to see the calibration and make a diagnosis. So this is the calibration, and if you see here, this has been done at the speed of the, this has been made at the speed of the 50 millimeter per second. A paper of speed 50 millimeter per second means it will print out the 50 millimeter in per second. Before we used to do at the 25 millimeter per second. This is are of 25 millimeter of second, and this is of 50 millimeter of second. And there will be the long interval between the QRX complex, which gives the impression of the slow heart. You will see that there is the P, then QRST, then again there will be P, QRST, and again there will be P, QRST, and so will be the RR interval will be so more. So you have to know the formula, because if you apply 300 by RR interval here, then that will be very wrong, because that concept is used only if that print 25 millimeter per second. If the ECG are printed in that formula, otherwise you cannot use over here. And also here you can see the RR interval are very near RR, because it is printed at the rate of 12.5 millimeter per second, because this has been, and this is 25 millimeter of second. So this might look tachycardia, because this is the printing are going very fast, but no, in that case you cannot do 300 divided by RR and make a concept about this. Okay, there is only 2 bucks to 150. No, this is not the way. So you have to be very cautious that in what speed that has been being printed. So here the printing has been done at the speed of the 50 millimeter of second, and here at the 12.5 millimeter of second. So you also need to know that at what speed the paper has been recorded, and at what calibration the reading has been made, at what calibration and what speed. So this might look the tachycardia, but no, it is not the tachycardia. Here you can see the paper speed of 12.5 millimeter of second, which is slower than normal. QRX complex are very close together, giving the impression of the rapid heart. P wave, QRX, and T wave all appear narrow and very spiky. While that in the opposite, in the upward, you will see widened QRX complex and the long, very QT interval. But in real, they are very normal, because we always see the ECG of the 25 millimeter of second, and we might make a misdiagnosis if we just make out our interpretation without knowing that the speed of the machine. So you need to know the calibration and also the speed of the paper before reading out the ECG. Now if we see this ECG, then there will be same very zigzag matter in the 1 to VL, 3 and VF, and some over here, and also here over 1, 2 and 3 VL, VR. So what is happening over here? So for this you need to understand that ECG recorders are tuned to the electrical frequency generated by the heart muscles, but they will also detect the contraction of the skeletal muscle. It is therefore essential that a patient is relaxed, warm and lying comfortably. If they are moving or shivering or having involuntary movements such as those of Parkinson's disease, the record will pick up a lot of muscular activity, which in extreme cases can mask the ECG, as you can see over here and here. This has been masking the ECG. So the ECG must, so to make out the good record, then we must get the patient comfortable and relax. So you can see over here, and here the same of you can see here Here the baseline is no longer clear and it is replaced by a series of the sharp irregular spikes, particularly marked in the limblets, because most of the patient will be moving their limbs. So in the limblets you will see, and because the chest they do not move, most of the chest you cannot move separately. So this will the chest lids can be somehow readable, but the limblets are very unlikely to be read. And there you can see here this is because of the severing. The spikes are more exaggerated than when patient is not relaxed. The sharp spikes are also more synchronized. The sharp are more synchronized because the skeletal muscle groups are contracting together. The effect of the skeletal muscle contraction almost obliterate those of cardiac muscle contraction in lead 1, 2, 3, because they will be moving their hands due to the severing. So you must make them calm and relaxed to make the proper reading, and you can identify whether this is the tachycardia or something like that, tachycardia or atrial fibrillation, or by looking the P wave, and also by looking the chest by comparing the limblets and the chest leads. In the chest leads, this is somehow very normal compared to that of the limblets. If you see the very much of different in the ECG pattern in the limblets and the chest leads, then that must click in your mind that there is something wrong, because the patient is moving here and there, and you might ask about the history with the nurse or the someone who is doing ECG, whether he was moving or not, whether he was severing or not. So you must be considering this point before making any diagnosis.